Okay, thank you very much, dear Chairman, dear ladies and gentlemen. I promise to keep on time. As you see here on my first slide, there's a perfect layout of my talk. It's about indications, contraindications, outcome, and cost effectiveness of TAVI versus surgical AV replacement. You see here the decision tree for aortic stenosis. The indication for replacement are patients with a severe aortic stenosis given as a valve area of less than 1 square centimeter or a gradient of more than 40 millimeters mercury mean. If patients have symptoms, this tree here is a class 1 indications for aortic valve replacement. And if patients have a decreased LV ejection fraction, it's the same. In these patients, surgical aortic valve replacement is indicated. And here is an old case series from Sweden, just to show you that there are excellent results for surgical aortic valve replacement with symptomatic severe aortic stenosis. And for the sake of time, I could stop my talk here if I hadn't 10 more minutes, and if not, there would be this. It's true, surgical aortic valve replacement is the gold standard, but we have the problem that not all patients with an indication, they get a surgical valve. As you see here from the Euro Heart Survey, from elderly patients with severe symptomatic aortic stenosis, only 2/3 get an intervention. And the reasons for not intervening on these patients are high risk or the age. And in these patients, also given the increasing age of our population, we have a large problem that we should address. The first that has addressed, or one of the first that has addressed this was Professor Crivier from Rouen. He has intervened in a very sick patient 11 years ago, and this has been published 2002. And this was the first implantation of a TAVI in a human being. At that time, it was a percutaneous heart valve, PHV, that was implanted. The patient didn't survive very long due to his comorbidities, but it was the proof of concept of something that has been shown to be a real winner in cardiology. You see here numbers from various countries, an increase of implants per million in almost all countries. Some countries, they have problems with economy. That's why those countries, they don't implant that much. Reimbursement is bad there. But in countries with a good reimbursement system and a quite healthy economy, you have really increasing rates. What about the data? We have 2 randomized trials, the partner trials, that have shown there is an evidence for TAVI treatment. The partner trials were two trials with patients with symptomatic severe aortic stenosis. One cohort was patients with a high surgical risk, and those patients, cohort A, they were randomized to surgical aortic valve replacement versus interventional in 2 strata for transapical and transfemoral. And the other group were not operable or inoperable patients that were treated with interventional valves against standard therapy, meaning medical management. These 2 trials have shown that there is an indication for TAVI in our patients. The first group, the inoperable patients, has shown in partner B that there is an improvement of survival in patients that were before not manageable. And those patients, they really get a benefit from TAVI. The other group were the patients with a high surgical risk, and you see here a quite interesting curve from partner A. At the end, after 2 years, you have the same mortality rate, but in between there's a treatment effect. The surgical group has a worse survival, but this levels out after long-term follow-up. So what's next after partner for TAVI? You see here a picture from Eurointervention. This is the risk of the patients, intermediate risk. Most patients are about here. This is a Gauss curve of the number of patients. And the higher you get, the less patients you have, and partner addressed these high-risk patients here. There's another trial coming, the SURTAVI trial for intermediate risk patients. This is a trial with a STS score between 3 or 4, depending on the continent you are, up to 8%. And these patients, they get evaluated in a heart team. And after this evaluation, if both strategies are amenable, they get randomized. Again, a stratification into coronary artery disease or not, and in pure interventional treatment against surgical treatment here. We don't have this data yet, but the next point I want to speak about is the risk scores. We have addressed that for MitraClip. I'm not agreeing with Peter. We saw, he has said that before, that the STS score is quite well depicting the risk of the patients. We see that these risk scores, they are purely not working in our patients. You see here, sorry, that was bad. You see here, this is the cohort from the core valve registry, and they analyzed the Euroscore 1 and the STS score, and here is the true 30-day mortality. You see that these scores are not doing what they should. They're not really giving the exact risk of our patients. So patients are more complex than the risk scores, I think. That's why we use our heart team for doing indications. In the guidelines, there's no word about risk scores. It's just about heart team. Just to lead you through here, it's about TAVI should be performed only in hospitals with a heart team, only in hospitals where is cardiac surgery on site. And TAVI is indicated if the heart team makes the indication for intervening on this patient by intervention or not. For high-risk patients, it's the heart team deciding it, and in inoperable patients, it's the same. Okay, what about the contraindications? Contraindications against TAVI is depicted here. This is also from the guidelines. I will lead you through here. It's the wrong button again. I will lead you through here. It's on the top, it's again absence of the heart team or absence of surgery on site. This is clear, has been shown before. And here are some clinical contraindications. It's clear a patient with a life expectancy less than 1 year, or severe comorbidities, or with another thing that has to be repaired on this patient, and this reparation can only be done by surgery. They shouldn't get a TAVI. There are some anatomical problems that should be addressed. Anatomical problems are the annulus size are too small or too large for our valves. However, there are some valves now manufactured. They could address this issue. Other things is thrombus intraventricular and endocarditis. There's the issue of coronary artery obstruction during implantation of the valve, or some other specific issues for the transfemoral approach here. Relative contraindications are bicuspid valves. The results are not that good there. Coronary artery disease that has not been treated, or hemodynamic instability a low ejection fraction, or for the transapical approach, it's pulmonary artery disease. This is because of the access or the LV apex not accessible. What are real data? We have a very nice publication from France showing that in it's more or less a partner A cohort, very sick patients, as you see here with the Euroscore of over 20, that all these patients, they get really a profit. Before, most of them were really sick with a heart failure 3 or 4. And afterwards, they get really a profit with a less severe heart failure. And I think this is the most impressive thing I always see when the patients, they are barely not able to walk into the hospital, and they get out by foot and well and alive. These are the outcomes. This is a very busy slide, outcomes in terms of mortality and complications. As you see in this cohort here, there's a mortality rate of about 10% for all-cause mortality and 7% for cardiovascular mortality. And this goes a little bit down for the transfemoral approach. There's an issue of stroke at about 2% of patients, myocardial infarction of 1% of patients, bleeding and vascular complications, and also the pacemaker that is double in the core valve than in the Edwards, as shown here. Speaking about complications, stroke is a very important issue. Strokes occur mainly during or after intervention, and strokes are associated with a very high mortality rate, in-hospital mortality rate, and a very severe disability of the patients. And some very nice publications have shown that there are some independent predictors of acute stroke in TAVI, namely balloon post-dilation of the valve that has implanted, the valve dislodgement and embolization during intervention, and more than one implantation attempt. Another issue is aortic regurgitation after TAVI. You see here a very interesting analysis of AR patients. Just to show you this, the AR index is something that shows that if you have an AR and this is hemodynamically relevant, the patient is really bad. The DBP, the diastolic blood pressure, LVEDP is clear, and this difference, if this difference is smaller than a quarter of the systolic pressure, you have a very high mortality rate, which is even higher when the AR is severe. But we are learning, this is the learning curve. This is from the PRAGMATIC Plus initiative. This is a couple of very large hospitals doing TAVI since a long time. And you see here that barely all complications are getting down over time. Tercile 1 to 3 are different periods. The first third, the middle third, and the last third since they began. And you see here the combined endpoint complications are going down, perhaps with the exception of strokes on the upper left corner. And finally, I want to talk about cost effectiveness. Giovanni Pedazzini has introduced the whole topic already. I don't go into it very much for the sake of time, but you see here that TAVI is with an incremental cost effectiveness ratio of 16,000 pounds in the same range as MitraClip and under the level of 20,000 pounds willingness to pay of the English government. And this is, by the way, data from the partner trials. This is from the partner A from TAVI versus surgical valve replacement. And what you see here is the cost drivers. On the left side, you have the TAVI. The most costly thing is the valve itself. and afterwards the rest is a little bit less expensive than on the other side. But at the end, both strategies are about the same. But what you see here is, again, this is the costs here. This is the cost, sorry. It's about the same. It's not going up or down. But what you see is a slight movement to the right, and the quality is better for TAVI, and that's why in this publication here, TAVI was regarded as dominant over surgical valve replacement. Okay. I want to conclude now with the following. We have growing numbers of TAVI. We have a large experience. This 50,000 TAVIs worldwide is outdated. It's at least, I think, double of it at the moment. Mortality is quite low for the high-risk population. We have complications, but the rates are falling fast. We have some established indications for TAVI for the partner trials, and we have ongoing trials that will evaluate the intermediate risk patient against surgery. I think the current tools for risk stratifications are not adequate at the moment, and that's why the heart team is important, that the surgeon and the cardiologist deal which patient they want to treat. And at the end, in the age of DRG, TAVI seems to be cost-effective in well-selected patients. That's all. Thank you very much for your attention.